Management, it's quite a complicated and multidisciplinary team approach that's needed here, and it all starts from when they first come in. In Scotland, the Scottish Hip Fracture Audit has set up something called the Big Six, which is the 6 key interventions from the front door that these patients need in order to give them a good outcome going forward. First up is pain relief. Now, for these patients, pumping them full of morphine is probably not a good idea. So a lot of trusts use something like oxycodone in short release form, regular doses, quite small doses, so that you can keep on top of their pain without sending them too opiatized.
Tim, opiatized is not a word. Please stick to bone chat. With love from the anaesthetists in the group.
Something else that's really useful is a fascioliaca block. Now these are usually performed in ED. As an FY1 on the ward, you shouldn't have to do these, but if you get the opportunity, it's something that's useful to learn how to do. Next up is a delirium screen. Now, each trust does this slightly differently. There's the single question in delirium, the 4AT, the AMT, whatever your trust uses. But it's really important to check cognition as soon as possible. It may sound daft, but making sure they've got a nicely recorded news and OBS chart and checking that they're well, that obviously makes a big difference. These patients need blood tests, full blood count, U's and E's, LFTs, bone profile, we'll come back to that later, a coag if you think it's relevant, if they've got risk factors for bleeding, and group and saves. They're going to need an operation at some point, so getting these group and saves off early makes a big difference. You can take these bloods while putting in a cannula, because these patients are going to need IV fluids. The final one of the big 6 is a pressure area assessment. A lot of these patients, they're not hugely mobile and they spend a lot of time in a bed or a chair. So checking on their high-risk pressure areas, you need to make sure that a plan's in place. This is often led by the nurses, but it's something to make sure you have an appreciation of. The clerking for these patients, often in each trust there's a pro forma, and it can be quite lengthy. But it makes sure that patients have a full holistic assessment and that nothing is missed. When prescribing drugs for these patients, make sure they've got some analgesia written up. Most places have a standard protocol for this, and also make sure they've got BTE prophylaxis. The last thing these patients need is a PE. Now for my favourite bit, operations. Before we talk about the details of the operation, I think it's really important that people understand why these patients need an operation. Because if you've got a 95-year-old nursing home resident who really doesn't mobilise, it can seem a little bit barbaric to put them through an operation, right? Well, it's all about risk. The first most important thing to get your head around is that these patients are not the same population who come to an elective clinic in orthopaedics for a hip replacement, although they may get some form of hip replacement after this. This, for your frail folk, is a palliative pain-relieving procedure above all else. What you're doing is making them more comfortable. What you're doing is making them easier to nurse and getting them out of bed. Lying in bed is not good for you when you're maybe not 21 years old anymore. You weaken, you get frail, you get chest infections, you get blood clots, and ultimately it's a pretty sore way to realistically end your life. What we need to do is get them up and get them moving. That keeps them healthy, keeps them strong, and ultimately does prevent mortality. It's a kind thing to do, that's the way you've got to think about it. By doing an operation here, what we're doing is we're giving them the best chance at a good outcome, although it does come with inevitable risk. If you do nothing, what you're doing is you're leaving them sore and you're leaving them bedbound. We need to talk a little bit about the different types of operation, because anyone who's done an orthopaedic job or spent any time on an orthopaedic ward can see there's a lot of different operations done for hip fracture patients. Now, let's keep this broad. When it comes to intracapsular fractures, as we said, blood supply damage, head dies, avascular necrosis, these patients with an intracapsular fracture, they need an arthroplasty of some form, a hip replacement of some form. Now, there's lots of different types of this. These can be broadly grouped into hemiarthroplasty, a half hip replacement. You're only replacing the ball that's been broken off the top of the femur, or total hip replacement. You're replacing the ball that's on top of the femur, and you're replacing the cup, giving them a matching set. For most patients, it's going to be a hemiarthroplasty. It's a quicker operation, they have good outcomes, and in a lot of units there's a variety of different hemiarthroplasties that can be performed based on the patient's functional status. Again, the patient who is wandering around doing their garden, going shopping, is going to get a different operation to the patient who is unfortunately bedbound in a nursing home. However, it's worth mentioning total hip replacements. Total hip replacements are a longer operation. It adds about half an hour, 40 minutes probably to the procedure, but in the right patient, they can make a big difference. The guidance says, and this is from NICE, that if the patient mobilises with 1 stick or less, is cognitively intact and is fit enough to undergo a longer procedure, they should be considered for a total hip replacement. Now, that doesn't necessarily mean they'll automatically get one. It's quite a complicated process to work out who needs a total hip replacement versus who needs a hemiarthroplasty. I'd leave that to the bosses. But it's worth knowing that for some patients, they will get the total hip replacement. So that's intracapsular fractures. Extracapsular fractures, remember, we don't need to worry about the blood supply. It's fine. So we can fix these. Now in orthopedics, fixing means plates and screws and nails. There's lots of different ways. I wouldn't get bogged down too deeply into these. You'll hear phrases like cannulated screws, DHS, CHS, intramedullary nails. They're all for extracapsular fractures and all mean that you keep the hip you have. As much as I like to think that it's the operation that makes a difference, the operation is actually a relatively small part of these patients' recovery. They need a comprehensive geriatric assessment. As we mentioned at the start, it's exactly the same patient population as those in geriatrics. They've just broken a bone and had to meet me. Once they've had their operation, they need to get out of bed as soon as possible. For most places, that's the same day or the next day. Even if it's just into the chair, we need to get these people moving. You need to get them eating, you need to get them drinking, you need to get them off IV fluids, and you need to get any catheters out. You need to get them back to what seems like a normal life as quick as possible. Orthogeriatric care is really important post-op. They're going to do things like medication reviews, stopping any medications that don't really have any proven benefit in people of over a certain age and frailty level. They're going to do a bone health review. We mentioned making sure that the patients have a bone profile earlier. It's important to check whether they need calcium or vitamin D supplementation or even bisphosphonate therapy for osteoporosis. All of this stuff, it's all about preventing a future fracture. We don't want these patients coming back with their other side. The final thing to think about is discharge planning. Now, some people will go straight home after a hip fracture. Other people may go back to their nursing home. But sometimes a hip fracture could be a marker that people aren't coping at home. And then you need to start thinking about increasing care needs, do a care assessment. Sometimes this is the trigger for people needing to go into residential care. It can take a long time to think about all these things. So again, the sooner it's started, the better. In a nutshell, hip fracture patients, they're quite complex. We all need to work as a team. It's a comprehensive assessment that needs to be done for these patients, and looking after them well from start to finish, that's what makes a difference. As always, don't forget to like and subscribe so you never miss a thing.